So, one of the common symptoms which a patient presents to emergency cardiac care is the chest pain. So, chest pain can be classified based on the ECG. So, anybody who comes the chest pain to emergency, the important thing apart from noting down the vital is to take an ECG. And in the ECG, we are particularly focusing on the ST segment. There's an ST elevation with the patient having chest pain. We call it as ST elevation MI or STEMI. So this is the one important group of disorder where the patient has acute chest pain. Remember, these are patients who have got acute chest pain. Now, those patients who do not have ST elevation, we can further subdivide based on the presence of or absence of biomarkers. We use two important biomarkers to identify the myocardial infarction. One is called troponin. So we have two type of troponin, troponin T and troponin I. Also, we use CKMB. Most of the Western world, we use troponin I. So if there is no ST segment elevation, but the troponin is elevated, we call as a non-ST elevation MI. Suppose the troponin is normal, but there are some ST changes which is not ST elevation and patient has acute chest pain. We call it as unstable angina. So USAP stands for unstable angina. Okay. So broadly, there are two types: ST elevation and non-ST elevation. The ST elevation with patient has chest pain, we call ST elevation MI. If there is no ST elevation, but patient has high biomarker, we call this non-ST elevation MI. And if the biomarkers are normal, there are some STT changes, but not elevation, but the patient is presenting with acute chest pain to emergency, we call it as unstable angina. Now, one of the important markers I mentioned for to diagnose myocardial infarction is troponin I and CKMB. But do remember, we have other enzymes which increase after MI. For example, we have myoglobin, which increases within 2 hours of myocardial infarction, reaches a peak in 6 to 9 hours, and may remain elevated up to 24 hours, but comes back to normal after 24 hours. Also, we have CKMB. Remember, CKMB is an isoform or a fraction isoform of CK enzyme. So the total enzyme is called as CPK or creatine kinase, creatine phosphokinase. So we have three isoforms: CKMB, MM, and BB. The one which is specific to cardia is called CKMB. It increases after 3 to 6 hours. It remains elevated for about 2 to 3 days and then comes back to normal. Troponin I is the one which is more sensitive and more commonly used in the practice. It increases only after 4 hours of myocardial infarction and comes back to normal in 3 to 5 days. AST and LDH are non-specific, may remain elevated for 4 to 5 days or 5 to 10 days respectively. Now, the two important enzymes what we commonly use in diagnosing is the CKMB and the troponin I. The one of the common question which appears in MRCP exam is: suppose you have a reinfarction within the fourth or fifth day, which is the enzyme which will be used? Okay, so what happens is, troponin I once gets elevated. You can see in the figure that troponin I or troponin T, both of them behave in a similar fashion here. Troponin T once elevated may remain elevated for 4 to 5 days, whereas the CKMB fraction, you can see here, CKMB fraction gets elevated and comes back to normal after 48 hours. So what happens if suppose you have in between here a second myocardial infarction, then it's better you do a CKMB rather than troponin I or troponin T, because troponin I or T is already elevated because of the previous MI. So if you're suspecting reinfarction or recurrence of chest pain, the good cardiac marker will be CKMB rather than a troponin. First enzyme to rise is myoglobin, but myoglobin is too non-specific, so we do not use in the diagnosis of myocardial infarction. So how to diagnose this acute coronary syndrome? As I suggest, patient should have chest pain. That is the history. Patient should have some ECG changes, either ST elevation, ST depression, and patient should have either elevated enzymes, either troponin I or CKMB. Now, all these patients who are coming to emergency with acute chest pain, you're suspecting cardiac etiology, you should give them aspirin 300 mg and nitrate for chest pain. If the nitrates are not available or patient does not respond to nitrates, we can try morphine. Now you need to add a second antiplatelet agent here. So, okay, so we have two options, either ticagrelor or clopidogrel. But do remember, in the UK, the general population has a heterogeneous response to clopidogrel. That means clopidogrel level and clopidogrel bioactivity differs from population to population in the UK. So clopidogrel is not preferred in UK. So the preferred drug in UK is the ticagrelor. And in addition, you may have to heparinize the patient. The preferred one is low molecular weight heparin, especially enoxaparin. So just to summarize, so far, if you have acute chest pain consisting of cardiac etiology, we need to give them aspirin, ticagrelor, nitrate, or morphine with low molecular weight heparin. And anyway, we are going to check the vitals. If the vitals are stable, does not require additional oxygen. Um, the drug which we give is antiplatelet drug called as iptifibatide or tirofibam. These are glycoprotein 2b3A receptor antagonist. Now, what is this glycoprotein 2b3A? These are the receptor which are present on the surface of the platelet. So these are essentially again antiplatelet drug. Now, these are given in a specific scenario when you are planning for an angiogram within 4 days. Coronary angiogram should be performed as soon as possible when if the patient is clinically stable. Okay, these are the guidelines for acute coronary syndrome. So once the patient comes to emergency room with acute coronary syndrome, we generally activate the cath lab, and the patient is shifted as soon as possible to a coronary angiogram after the giving him the dose of aspirin, clopidogrel, or ticagrelor, nitrates, low molecular heparin, and morphine if required. Now, coming to the myocardial infarction. So, we have briefly discussed about anatomy of the myocardial coronary arteries. We know there are two types of coronary artery, right and the left. The right coronary artery supplies the conduction system of the heart. So, SA node in 60%, AV node in 90%. So, somebody has a right coronary artery which supplies the inferior wall of the heart. That is what you get in inferior wall MI. More likely that these patients you may have a heart block. So how do you say which area of the cardia is affected? So if V1 to V4 represent the anterior and the septum of the heart, so they're anteroseptal artery, and the artery which is anteroseptal MI, the artery which supplies is the left anterior descending, which is one of the major branch of left coronary artery. Inferior wall is supplied by the right coronary artery, so you get ST changes in the 2-3 AVF. Anterolateral is usually from V4 to 1 AVL. Usually it could be left anterior descending or left circumflex artery. Both are branches of left coronary artery. Lateral wall MI, you get lead 1, V5, V6 and AVL. So it is usually secondary to left circumflex femoral artery. We have the rare what's called posterior wall MI. So since we do not have a posterior lead, what you are generally seeing is in the changes happening in the V1, V2. Why V1, V2 are exactly opposite to the posterior wall. So you may get some reciprocal changes in V1 and V2. So commonly what you get is a tall R wave or a tall T wave. So that indicates probably a posterior wall MI. Posterior wall MI can come either because of the left circumflex or because of the right coronary artery involvement. Uh, in patients who have got a proximal left anterior descending stenosis, which is one of the major vessel which is involved in coronary artery disease, there could be a severe T wave inversions. Okay, so normally you get T wave inversion in ischemia, but this is a condition where there's a proximal left anterior descending occlusion. So that means there's a big area of the left ventricle which is infarcted. Okay, and that results in a symmetrical T wave inversion, also called biphasic T waves. Okay, and this phenomena, where instead of ST segment elevation, we are seeing a T wave inversion, which is a deep symmetrical, we call as Valence syndrome. So Valence syndrome is a manifestation of proximal left anterior descending occlusion, where the patient will present with chest pain and the ECG will show symmetrical T wave inversion in the anterior precordial lead. That means V1, V2, V3, and V4. Now, patients with the inferior wall, as I mentioned, who have involvement of the right coronary artery, usually have the AV block. So they can have first degree, second degree, or third degree AV block. Now, all patients, in addition to the aspirin and statins, we should also give them ACE inhibitor or beta blocker because they is found to reduce the mortality. If after MI, these drugs need to be started within like 3 to 14 days, especially ACE inhibitor. So there are some diagnoses which may get confused with the ST elevation MI. So one such diagnosis is called Prinzmetal's angina. Here, basically, the patient is going to present with chest pain. ECG will show ST elevation, but the troponin will be normal. Okay, this is called Prinzmetal's angina. This is because of the coronary vasospasm, and generally we treat them with the vasodilator, especially nifedipine is the drug of choice for Prinzmetal's angina. This is an ECG which is depicting the various type of coronary artery which is involved. So we have lead 1, lead 2, lead 3. We have lead AVR, we have lead AVL, and lead AVF. We have precordial leads V1, V2, V3, V4, V5, V6. Okay. Now, if there are ST elevation in 2, 3 AVF, we call as inferior wall MI, and it's usually secondary to occlusion of the right coronary artery. With a similar principle, if there's involved ST elevation in V1, V2, V3, V4, we call it as an anterior wall MI, and the culprit vessel is the left anterior descending. If there's ST elevation in 1, V5, V6, okay, AVL as well, we call it lateral wall MI, and the culprit artery here is the left circumflex artery, which is a branch of left coronary artery.